Okay. Hi, everybody. Welcome to tonight's fireside chat with epidemiologist Glenn Grossman. I am Rebecca Berman, our moderator for tonight's discussion. And just want to kick off our conversation by once again saying how grateful I am, and so many of us are, for Glenn and all of his hard work and just really being our tour guide for so many months and so many slides into this pandemic. When we last met, we were approaching 1,000 slides when we were learning about T cells and mRNA and different receptors and different types of transmission. And I feel like you have just broken it all down and built it back up for us. And I, for one, have always felt grateful for you, and even more now, feel even more grateful for you. So thank you, thank you, thank you. And I also want to say, on behalf of all of us, if you yourself have contracted COVID or know somebody who has, a friend, a loved one, you are all in our thoughts and prayers, and we're wishing them, you, your loved ones, your friends, a very, very speedy recovery. And we hope that part of our discussions, our ongoing discussions, can be helpful to you and your friends and your loved ones as we all get through this together. So, as we know, Glenn Grossman is an esteemed epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, Military Health Service, CDC, and other programs in the United States and abroad. He currently is Senior Director of Outcomes Research and Epidemiology at Novartis, but all views today expressed are his own. So thank you to everybody who has sent in questions during the week. Glenn has woven those into our conversation tonight. And if you have questions that come up during our conversation, please send them to me privately via the chat button at the bottom of your screen, and I will do my very best to get them into the conversation tonight. If not, we will resume with your questions next week. So Glenn, how are things looking here in the United States? And take us around the world. How do we compare to what's going on around the world?
Hey, Rebecca, thanks for your great introduction, as always, and thank you very much for all the work that you've done and helping to put this all together every week for the many months you've been doing it. I just looked at my slides. We're not quite at 1,000 yet. Maybe next week we'll hit the 1,000 mark. I don't know. We'll see how much news there is next week. But yeah. So let's see. Let's get started and share my screen. Yeah, so we had a really tough week this past week in terms of COVID news. First of all, for me, I was very honored to be on a panel with 2 other people. One person was on the board of directors for IHME, which is some of the models that we've been talking about. It's the Institute for Health Metrics and Evaluation. And so some of these models that we've been talking about, I was on the board on a panel discussion with one of the people on this board, and then also the Imperial College, which did some great modeling earlier on in the year. And so it was a fun experience to be on the panel discussion with them. And so now let's talk about COVID in terms of the United States. What are we looking at? Let me go to this one. All right, so as you can see, things are really not in good shape in the United States. We had this little dip here in cases that was due to Thanksgiving time. People just weren't going and getting tested. They were still getting sick and they still had symptoms during that time, but either they delayed getting tested or the test results were delayed in terms of entering into the data management systems. For whatever reason, you can see that it was not a real change in the cases. It was more of a data issue. And so now what we're seeing is by far the highest number of daily cases that we've seen We were at over 200,000, but we're continuing to rise in terms of the number per day. More importantly is the number of hospitalized. And as you can see, we've exceeded 100,000 currently hospitalized at one time. Over 90% of all the hospitals in the United States currently are stretched. And so one of the key differences with earlier in the year is that not all the hospitals were stretched at the same time. So if one state was being hard hit, they could, whoops. So if one state was being hit hard, one more time, then they could borrow personnel, they could borrow equipment from other nearby states or other nearby hospitals. In contrast, if 90% are stretched or at their near their limits, then there's not much spare capacity. And so we're really, really on the edge in terms of what we can handle. So this is a really challenging time for the United States. So a lot of hospitalizations. Next, you see that this is the key thing in terms of the number of deaths. So the average number of deaths in the last week is now 2,123. We have now exceeded the number of total deaths in the at the peak of the first surge that hit us so hard back in March, April, June, and May, June, and you see that we're still on a exponential growth curve. This is not stopping anytime soon, so we are going to go far past this. The question is how much further past this will we go? And a little bit later, we can maybe talk about projections if there's an interest in that. I thought I'd take this opportunity. So we've been talking about total deaths in terms of how many that we're looking at. But one important thing that I've talked about before is the total excess deaths versus the total reported deaths. So the CDC, let me go to the CDC's website for 1 second. All right, so here's the CDC website. Here is the total number of deaths by state. You see some states were hit much harder than others. The darker the blue, the harder it was hit, the number of states. We can look at this reported as per 100,000 or per that or totals. So you can see as the per 100,000 is normalizes it because some states are bigger than others. So you see Texas, when you compare it in terms of their capacity, because that's a very big state, doesn't look like it's so bad. But when you look at it in terms of totals, you see Texas, California, Florida actually look like they were hit much harder. But so they had a lot of deaths there, but the proportional number of deaths wasn't actually so bad. But so this goes back. So here's the total number of deaths we're looking at. So in terms of the number of total diagnosed COVID-19 deaths, that number is 280,000 that you might have been hearing about in the news. Within weeks, we'll be hearing about. So I mean, we're looking at 2,000 plus deaths per day. So within a very short period of time, 1 to 2 weeks, we'll be hitting the 300,000 death mark. However, one thing that you'll notice is that when you look at all the excess deaths in the United States, as of December 6th, we are over 400,000 in terms of excess deaths. And I thought that this was something that was an interesting thing because there's 2 reasons why there might be excess deaths right now. One reason that there might be excess deaths, here, let me come and look at this website now. So one reason that there might be excess deaths is because, and this is the CDC excess death website. One reason that there might be excess deaths is down here is because of misclassification. And so for instance, an example of misclassification is that someone might have had a blood clot because they had SARS-CoV-2. They didn't really have any other symptoms, but they got a blood clot because of SARS-CoV-2, and it caused them to have a heart attack or a stroke, and they died from it. In this case, it might have been misclassified and just listed as a heart attack or a stroke, when in reality it was COVID-19 was the cause of death. And so that might be why some of the excess death was caused by that. Other reasons are due to the stress or burden of the disease. So for instance, as you can imagine, there is probably more suicide going on during the course of this year. There's probably more drug overdose deaths. definitely in some long-term care facilities. If they weren't allowed visitation, then some people there might have gotten lonely, and that might have contributed to a decline in their overall health and might have contributed to an early death. And so the question is how much of this extra death that's not diagnosed is due to misclassification, and how much is due to this stress and burden that's not a direct infection, but a consequence of the epidemic in general. So what I did is I looked at New York City. This is just a very back of the envelope analysis I'm going to walk you through. Within the coming months, I'm certain there's going to be some good publications looking at how this distribution looks around the country. What I like about New York City is that it's nice and clean because they had the first surge in New York City and then it went down and then they've had it under control for much of the year. And so because of that, it's really clean. And what I looked at this is in orange, this is the total diagnosed COVID-19 deaths in New York City in this period of time. The blue is the excess deaths not diagnosed as COVID-19. And so I looked at the proportion of the total excess deaths that were due to to the undiagnosed COVID-19. And as you see, it's decreasing over time. And so for me, I would conclude that this is likely due to misclassification, that the physicians, that the hospitals, that the whole system got better at diagnosing COVID-19 over time. And the reason for this is that if it wasn't due to misclassification, if it was due instead to the stress and burden of the disease, then I would have expected the stress and burden to get worse as time went on. So for instance, the shutdown, which lasted many weeks over this period, I would have expected that people would have had a harder time toward in the second month of it or later over the summer rather than in the first week or the second week. And so because of this, my conclusion is that at least for the first surge in New York City, it was largely misclassification. So in truth, the excess deaths largely represent the true COVID-19 infection fatalities. And so that's my interpretation so far. As the year has progressed, it might not be the same in other jurisdictions, but really this analysis is going to need to be done sort of at the county by county level across the United States, and I haven't seen an analysis like that completed. So that's pretty much it. I can stop with there. Let me go back to United States if there's anything else that's interesting to talk about here. All right, so another thing to talk about is Thanksgiving. So Thanksgiving was a little over a week ago, and so some of the cases will just start coming in now. So some of the bumps that we're seeing here are some of these cases that have just started coming from Thanksgiving, but probably over the next week. So when we circle back on Sunday of next week, we'll have a lot more data looking at the impact from Thanksgiving, and that'll also help to inform what the likely impact of the Christmas holidays will look like and New Year's Eve. And so you can see that right now we're still on an exponential growth curve with cases. The hospitalization is still growing rapidly, and the death rate. Just as an aside, right now our best estimate is that on average there's approximately an 18-day lag between when a case is identified and when there's and when the death data goes up. It's for approximately 18 days. So that means that from Thanksgiving, it'll take a few days before someone is diagnosed and show up in the cases. And then approximately 18 days after that is when you would start to see the death data rise. And in between, the hospitalization rate's going to rise. So again, Thanksgiving is just barely reflected. Maybe over the last couple of days when we're seeing these spikes, we're beginning to see some of the early impacts, but that's that we have a ways to go. And that's where we are here. All right, I think one more thing I wanted to show was the hospitalization. So here is the numbers currently hospitalized. This is in absolute numbers. So when you're looking at where all the patients are in the country, you can see that the bigger states tend to have more patients, and that just makes sense. It doesn't necessarily mean they're getting hit harder, it's just that they're bigger states. So an interesting thing to do is to look at the proportion. So when we normalize it and look at the number hospitalized per million, this really is the reflection of how hard the hospitals are stretching. Because pretty much anything in black represents hospital systems that are stretching and that are near the breaking point. So when you look around the country, you can see that there are a lot of states that are stretching, that their hospitals are in bad shape and are near the breaking point. Um, and we've heard about California beginning to shut down, talk about shutting down much of the state based on where they are at 260. And you see that there's many other states that are still open that have relative numbers that are far higher than the 260. So this is something that we're going to be looking at. Right now, I talk to colleagues and healthcare providers who are around the country, and this is crisis mode. It's not just a crisis for the people suffering; it's a crisis for the healthcare providers because they're stressed out. They're not getting enough sleep. You can imagine it's because of HIPAA rules, the patient privacy. We're not seeing these scenes of crisis in the hospitals right now. It's mostly just people talking about it with words, but in reality, each one of these dark gray bubbles are crises happening at hospitals all around the states. These, when we talk about the total number of people that are dying, these are impacting families all across the state, all across each of these states. And so, I mean, when we literally talk about that just in the past day, so December 5th, that almost 2,500 people died. I mean, that's almost as many people have died as in 9/11. And this is huge. So the urgency that we felt with 9/11 is what people around the country are feeling every single day. And when you look at the average here, the average the weekly average per day is 2,123, and you can see when you look at this curve how big how it's growing. We're not near the peak yet, and so in a little while we'll talk about the projections possibly, but this is a crisis. This is one of the nation's worst crises, at least in terms of a pandemic, in 100 years, and if not more, in terms of the impact that we're having in different ways on different people now. And so, and yeah, this is it. Right now, the executive branch is really continuing to not do enough. We have the approach taken by the president earlier in the year, which I disagreed with, but at least it was an approach, was to try to manage the anxiety of the population. And that was why he was not telling us all the key information we needed to know. But now we haven't even heard anything about COVID-19, this crisis. We've just hit a highest peak that we've had so far in the whole crisis this year. Haven't heard anything from the president of the United States on this in the last few weeks. So from President Trump. So I'm hoping that rapidly on January 20th, when the new administration comes in, they'll start to be able to manage things differently. But I think this doesn't change on a dime. So over here, when you had the peak going up, then you had the whole downward peak, and the downward part of the peak of the curve took months to overcome. So the question is, okay, after January 20th, when we have a change in management, how many months will it take to come down on the other side, and how many people will die as a result of that? And so it's just a tricky thing. Globally, the United States is doing pretty poorly relative to other countries. This is the United States. But there's a lot of questions, and I've been spending too much time on this. Let's revisit the global stuff next week and just get into questions now, just because there's so many interesting questions this week that I wanted to get into.
Okay.
So back.
Let's do that. Absolutely. So we've talked about this a little bit in the past about the flu and how a bit of a silver lining in all of the mask wearing and the different approaches to hygiene has been that the flu has been significantly less of a problem this year than in years past. Is that consistent with what you're seeing?
The flu has been much, much less this year versus years past. So when you look at the state by state level, you see that there is a little bit of flu, but it's almost entirely minimal. In some states, it's considered low, but you see many states have virtually no flu. So this is great news. It's one of the best flu seasons we've had on record. for whatever that's worth in the context of the COVID-19 crisis going on. We luckily, because of our mask wearing and our staying at home and our physical distancing and all the other things that we're doing, it's the flu is really not really contributing to excess mortality right now or morbidity.
All right, we'll take it. I'll take that as good news. Well, how about you? You'll take it? All right.
Absolutely.
I like seeing an all green and slightly yellow map. I'll take it. Great. Excellent. Okay. Next question. Some people swear that they've had COVID-19 symptoms before January. So about a year ago. Is there any evidence that SARS-CoV-2 was spreading in the United States before around this time, about a year ago?
Yeah. So a lot of epidemiologists were skeptical about this for a while. And the major reason being that because of how quickly the virus spreads, we thought that if there was any virus circulating back before March or before February, we would have already seen spikes at least in deaths or something earlier on. And so there's a lot of skepticism from epidemiologists because of this. However, there was an interesting study done. It was just published November 30th, so just a few days ago. And it looked at blood donations. So there's always a portion of the blood that's donated is stored for future research use, just in case, specifically for cases like this. If there's respiratory illnesses or circulating virus, then you can go back into these banks of stored blood over months or years and see where it was historically. And so they said, okay, this is a great opportunity to go into these saved blood banks from these blood donations and see if there was any SARS-CoV-2 in it. And sure enough, what they found was that there was. They started looking at just looking for the virus between December 13th to January 17th. And sure enough, between December 13th and 16th, they were able to identify several samples that had evidence of the SARS-CoV-2 virus in it. There were more over time, not dramatically more over time. They thought, well, maybe they could be false positives. They went back and tested that. They're unlikely to be false positives. They did a lot of really rigorous testing on this. One of these was to compare. These ELISA tests, let me bring it to the front, just to look at the neutralizing titers versus the immunoglobulins versus the antibodies. So they really looked at this in a way that's really compelling. And so now a lot of us believe, based on this evidence, and some others that were reported based on some other studies that were done, but I would think primarily because of this, that yes, there was SARS-CoV-2 circulating in parts of the United States before January of 2020. So as early as early to mid-December. And the ones that triggered it in December were from residents of California. So that was where it was circulating first. It was then, and Oregon and Washington is where it was found in December. After that, it was found December 30th. And between December 30th and January 17th, was found in Massachusetts, Wisconsin, Iowa, Michigan, Connecticut, or Rhode Island. And so this is just a subset of some of the states that were evaluated. I don't think that they looked at all the states. Yeah, I think that they only looked at these 9 states because that's where the infections were first identified, I think back in February, and that's why those were selected. But yeah, so this is interesting. They did not evaluate before December 13th, so who knows how much sooner before December 13th it was circulating. They didn't find it in any of these other states, but yeah, it's fascinating.
What should people do with that data if somebody kind of thinks back about a year ago, and if they're living in one of those states or visited one of those states, let's say, and they think, oh my goodness, I was really sick and I kind of assumed it was the flu, but I didn't get tested. And so what do they do now if they think, oh goodness, maybe I did have SARS-CoV-2 back then? Should they do anything differently now?
Well, so first of all, the question is, do they have protective immunity? And it's very likely that they do. However, we don't know for sure. So some studies have indicated that maybe people lose their protective immunity if they get it within 3 months. Others say, oh, well, maybe we think it will be protective for at least 18 months. So if someone was infected back in December of 2019 and it's 18 months, then that puts them what into like May of 2021. And so still I don't know. And these protective durations are averages. So for any individual, we don't know. It could be more, it could be less. So I don't know what to do with that information. The other thing that we do know is that among people who are infected, a portion of them, if they're reinfected, are likely to get more severe disease. So rather than immunoprotection, it actually makes them more likely to get very sick or die. So just because they may have been infected back in December or January, do not use that as a reason to think you now have protective immunity, because if you get infected again, it could put you in the hospital.
All
Yeah.
right, good to know.
Before we go on, one other thing. So one of the things that we found, and this is something we didn't know back then, or back in March or April, is that the majority of the spread are actually through super spreader events rather than through one-on-one spreading. And so as a result, that could be one of the reasons that we didn't see massive spreading back in December or January, because it could be that many of these people who are infected were actually not super spreading the disease. And as a result, it could have been that the R value was much smaller as a result. But then approximately at the end of February, early March, it would have hit some threshold, and then much super spreading events happened much more rapidly, and that's why it really took off in the ways that we saw it back then.
Goodness, that makes sense. And here we are, almost a year later. So here we are, almost a year later. And we've got some good news on multiple vaccines. So tell us, where are we with the vaccines? What has happened since we've last spoken? When will they be available? Who's going to get it first? And what are the timelines?
All right. So, update on the vaccine. So, I don't think we discussed the Moderna vaccine since we last met last Sunday. And so, let me, just in case, go through some of the amazing findings that we saw. So, first of all, this is the Moderna. So this is the the other messenger RNA vaccine that's in addition to the Pfizer vaccine that we previously talked about. The Moderna vaccine was part of the US's Operation Warp Speed for the vaccination process, and the United States paid Moderna a lot of money not just for the doses that we'll be receiving, but also simply to do the research, to conduct the clinical trials, and that kind of stuff. In contrast, the US did not use Operation Warp Speed funding for Pfizer, but they did guarantee that they would purchase some of the doses of the vaccine, or many doses of the vaccine. But Moderna got extra treatment, and so as a result, US is prioritized for Moderna for getting the vaccine. So Pfizer, for instance, was given extra money by Europe, but not by the US. So they may be prioritizing distributing some of their vaccine for Europe rather than the US, which makes sense. I mean, that's one of the reasons that Europe gave it. It's the same reason for Operation Warp Speed, why we gave money, so we're prioritized for the companies that we selected. So anyway, here's Moderna. Moderna, here are the key results. So Pfizer had approximately 40,000 people enrolled, with roughly half getting the vaccine. Moderna had approximately 30,000 people enrolled, with approximately half getting the vaccine. What they found was that only 11 people who received the vaccine developed any symptoms, and 185 people who received the placebo group developed symptoms. So this is hugely, hugely protective. If the vaccine were not protective, then you would have expected around 185 symptoms in the vaccine arm too, and you only saw 11. So this is huge. This is equal to an efficacy of about 94%. But as I mentioned previously, in terms of some of my key questions, one of my key questions, was, we don't really care about mild or moderate symptoms. What we really care about are severe symptoms or hospitalization or mortality. And so one of the things that they looked at here was severe symptoms. And what they found was that there were 30 people in the placebo group that had severe or very severe symptoms. And there were not a single person in the vaccine group that developed severe symptoms. So this is amazing. If the vaccine was not effective for the severe group, then you would have expected around 30 severe cases in the vaccine group, and they had zero. So this is amazing news. The vaccines are very likely to be extremely effective. Because there were not a single case of severe disease in the vaccine group, then that means it's much, much less likely that there's going to be hospitalization in the vaccine group. So it'll probably be strongly protective against hospitalization. And most likely it'll be much more strongly protective against mortality and death. So this is amazing news. Um, let's see. Pfizer just released a little bit more of its data, and so there were 10 severe cases total, and just one was in the vaccinated group. So they had 9 in the placebo group and one in the vaccinated group. So that's a 90% protection from the vaccine for severe disease. Again, amazing. And so Moderna is plans to have 20 million doses, 20 million vaccine doses available by the end of this year. So it's already December 6th. So within just a few weeks, 20 million doses will be available. Pfizer says it will plan to have 50 million doses globally, and that's going to be split between the United States and the other countries that already have these purchase agreements. So already within weeks, we have tens of millions of these doses that will be available. The one thing that I need to remind you about is that this is a 2-dose regimen. So you need to get your first dose and then wait a period of time and then go back and get the second dose in order for it to be effective. I think I agree with Paul Offit, who's a very prominent vaccine researcher. He really knows his stuff. In fact, he's on the board that's this independent committee of vaccine experts that advises the FDA. And I've been cautiously optimistic, but I'm becoming less and less cautious. I'm much more optimistic now, the more as data is released. Even though these are pretty small numbers, 185, 10, 30, then it's all consistent in terms of what we're seeing. And so I'm definitely getting more and more optimistic. And right now I'm at the point that if I were eligible to be given the vaccine today, right now, given everything that I know, I would. And so this is similar to what we're hearing. I would still like to see all of the actual data, absolutely. But what we've seen so far is absolutely remarkable. And so this is great news. Let me go on now and to dig into this a little bit more. All right, so this was a survey. It was reported on by the Institute for Health Metrics and Evaluation. And this was looking at the estimated proportion of adults that is open to receiving a COVID-19 vaccine based on Facebook survey responses. And you see that there is a lot of vaccine hesitancy around the country. You see that some of the states that are most likely to get it, New Jersey, California, some of these others, that there's only a few of them, only a handful. There's a lot of states out there. There's a handful that are 60 to 70%. Only 60 to 70% of them are willing to get the vaccine, which is not near enough. One of the key things we don't know about the vaccines yet is whether you can still be contagious. Because we know with the vaccines that some people will still be, or most people will still be infected, or we don't know exactly what percentage will still be infected. And what we've seen are looking at symptoms, that it has this massive reduction in symptoms, but we don't know how contagious it is. And so that means the worry is, what if people start getting the vaccine, then they figure, oh, great, we can start partying again. Their risk is really low. Go back out to the bars, go party, take off the masks. Then suddenly, if they are still contagious, they could spread the virus to many people, to dozens of people around them. And then you might see a new spike of people getting infected, getting hospitalized and dying, who are themselves not vaccinated. So we don't know about how effective people might still be after. And so that's something that is worrying me a little bit. A couple more things. One, I talked earlier in the year about antibody-dependent enhancements, and as more and more information is coming out, it's less and less likely that antibody-dependent enhancements are anything to worry about for these vaccines. One, because it's focused very, very precisely just on the S antigen, but then two, in terms of the real-world data, or in the clinical trial data here, um, we would have likely seen an impact on the of the antibody dependent enhancement in the vaccine group if it existed. And so the fact that we're seeing such strong protection means that it's very, very unlikely to be the case. Finally, I wanted to look at is this something I wanted to look over here? So find your place in the vaccine line. The vaccine's probably not going to be available to all people all at once. Instead, it's going to be rolled out. And so basically, there's a great article from the New York Times that I liked how they took all the evidence that we have and put it into a great piece. And so find your place on the vaccine line. So typically, the things that are prioritized are first people over the age of 65, then people under the age of 30 or under the age of 31, because the people in their 20s and younger are the ones who are likely to go out to go to school, and the 20-year-olds are the ones who are out partying, so they're more likely to spread it. So there's a prioritization in terms of who's going to get the vaccine. Plus, in addition to the age, there's different professions. Healthcare workers are going to get priority, essential workers, first responders, or teachers, or people who have comorbidities. So I was looking, if you're a 31-year-old, I live in Somerset County, New Jersey. I don't fit into any one of these frontline workers. I'm not a teacher or any of these other things. I have no COVID-19 related risks. Where do I sit on the line? And unfortunately for me, there are 269 million people ahead of me in line to get a vaccine. So let me go through the list. So most likely the people who are going to get the vaccine first are the roughly 500,000 healthcare workers in the United States. That's a lot. But remember, there are tens of millions of vaccine doses available. So there's still a lot of people who can get it, even after the healthcare workers. Then nursing homes. So 85,000 people living in nursing homes, 41,000 first responders, 2.3 million with the high health risks, so these comorbidities. So then you go down the line after all of these people, keep on going down the line. Then you have 283,000 other elderly. After that, you have 326,000 essential workers. Keep on going. Then you have 204,000 teachers. Then you have homeless people, prisoners. Then you have roughly a million young adults. Then after the young adults, then you have the children. Now remember, the children can still get infected, but their symptoms tend to be much, much, much lower risk. But because they're going to school, you have so many potential kids that could get infected that you do see some kids getting severe illness and dying. And so that's why we do the young kids under the age of 18 next. So then you keep on going down the list. There's 250,000 other essential workers, then 1.9 million others, and then you get to me. Oh well. So essentially people under the age of 65, but over the age of 30, who have no comorbidities, no serious illness, and are not in one of these professions that are the high risk professions. We're at the end of the line. But like I said, one of the benefits for us is so personally, because there's all this vaccine hesitancy, then that might mean that I can get the vaccine a little bit ahead of other people, simply because they could get the vaccine, but they're selecting not to get it. But anyway, that's where we are here. In terms of the timelines, so these are the likely timelines that we're looking at. It's just an estimate from Business Insider, but I think that they're pretty accurate. So December 7th, December 8th, the FDA is about to announce that they're discussing the emergency use authorizations, if it hasn't happened already. By December 10th, the advisory committee will meet. By December 11th to 12th, then we're assuming that we'll hear this coming week about the vaccine being authorized for emergency use authorization shortly after, because Pfizer, if you recall, reported their results first. And so it's going to be evaluated first. Then Moderna coming around December 17th. And And then by December 21st, we're expecting that the decision will be there sometime around then. In terms of when people will be starting to get the vaccine, so the first vaccine will likely be available sometime this month. Then, and I said the pecking order, I said that earlier. So the priority groups it'll roll out December and January. February, March, April, it'll be distributed more, with approximately 30 million vaccines distributed every month. April, May, June, vaccines are going to become much more widely available for young people, people under the age of 18. If they're considering going to summer camp, then if it becomes available for them, let's say March, April, May, or May, June, then if they need the 2 doses, if they got one at the end of April, one at the end of May, then that would set them up for being fully vaccinated, fully capable of returning to their life at normal at summer camp. Most adults will probably get vaccinated by the end of next year. But as you know, because this is a seasonal thing that we're experiencing, we'll probably be able to expect that the same way that by approximately May or so, the first surge ended in the United States, we can expect the same thing to happen back in the coming May, that the numbers of infections and deaths will have already gone way down by then as the weather gets nicer in May, June. All right, that's enough for that. Are there any questions on that so far?
I think it's really interesting that I see by October, November, assuming everybody who we anticipate will be getting the vaccine gets it, that we could reach this herd immunity.
Yeah, the whole concept of herd immunity, even with the vaccines, it's a little bit tricky because here's the question. Herd immunity is an average. And so it means if we reach that herd immunity point, then we won't have these massive shutdowns. But say you're in an office environment and there's 30 other people in the office and very few people have gotten the vaccine or previously been infected. If one person goes in and things are back to normal by that point, then they could infect potentially everyone else in that office, or easily 70-80% of the people in the office in a super spreader event. And so the herd immunity, we have to take it with a grain of salt, because it doesn't necessarily mean that you personally are protected if you're in a large crowd. What it means is that on average across states and at the high level, you won't have these massive outbreaks that cause the shutdowns that we're seeing. The other thing is the vaccine hesitancy is going to be a massive issue. So again, let me come back to this idea. You see, so some states like New Jersey and some of these others are set up for success because there's a lot of people who are going to be seeking out these vaccines. But in a lot of states, they're not at the 75% level. I mean, there's going to be some protective immunity from people who have already gotten infected, but presumably a portion of people who are already infected will also want to get the vaccine, either because they weren't sure if they were previously vaccinated or whatnot. And so as a result, they might still not reach that herd immunity threshold, which we still are not quite certain what it is. In some of these states, they're going to still be at risk for who knows how long. And that's problematic.
All right. Well, we'll take another bit of the good news. We'll take it. And I see lots of green on this map. So that's, I think, the theme of this evening is green. Green equals good. And we will just keep on taking it. So let's jump to the Minks. We spoke many weeks ago about Minks. And there was an outbreak of SARS-CoV-2 in the population of Minks in, remind me, which country?
Well, there was a bunch of countries. So in the United States, in Netherlands, in the Danish fur farms, but there've been a bunch of countries. What we just heard about in the last week or so is that so they were doing a major cull in Denmark, but what they found is that at least 100 minks escaped. And so some of these were infected with SARS-CoV-2 and have now escaped into the wild. And the worry about SARS-CoV-2 was that it mutated a little bit when it infected the minks, because the minks ACE2 receptors are a little bit different than ours. And so as a result, it mutated to be optimized for the minks. And now the worry is that if these minks in the wild now get eaten by another predator or drop their feces and other predators come into contact with it, then there could be infection in the local ecosystems of the animals that live there. And the problem with that, potentially, the risk is still somewhat small because 100 is not a large number and only a portion of those were infected with SARS-CoV-2. We don't know how many. But the worry is then it could jump to another species or another species in that time. And what we know is that when viruses jump from species, that's one of the key triggers that shifts the mutations. It gives a different selective pressure because the ACE2 receptors are slightly different and it optimizes towards the new species. The problem is then it could then reinfect humans at some point and could be an even more serious disease than we have now. Either it could become different enough from our current vaccines that the vaccines won't work on it, or it could become more severe or have different properties than it currently has. So right now, it's not a big concern, but it's just something that people are paying attention to, just to be aware in case we need to worry about it.
Oh, goodness. Oh, goodness. Well, they are very cute.
They are adorable.
They are. And Harry, I see you have a very cute little creature, or you did over there. And Harry, I'm going to ask you to unmute because Harry brought up a very interesting point, a very good question going back to the vaccinations and some folks not being inclined to take the vaccine at the on this first round here. So I'm going to ask you to unmute. Nope, we can't hear you just yet. Or maybe I can unmute you. No, I can't. There you are. I can.
Okay, so the question that I have is going back to your graph where there are different populations and states. Many states are very inclined to have the vaccination, but there's a lot of states where there's significant resistance to the population. So the question is, you've got this limited supply of vaccine available for the total population of the United States. How is the government going to prevent vaccine from being wasted by going to places where it's not going to be utilized?
It's a really good question. I don't think it's going to be wasted anywhere. I think that it's just going to be changed. There might be a shift in the prioritization. So for instance, if there's a state with low vaccine hesitancy, my understanding is that the federal government, I believe, is planning to distribute to the states based on the burden in the states. But then it's up to the states themselves to decide how they distribute it within the states. So what I suspect is that states with a lot of vaccine hesitancy will make the vaccine available based on the order in which they believe, in terms of the healthcare providers first, then the high risk people, et cetera. But it just could be that if people are less willing to get vaccinated, that people further down on the line will get a better chance in those states of getting vaccinated. The other thing, this is one other interesting thing. So the Pfizer vaccine, if you recall, requires to be stored at really, really cold temperatures. And the infrastructure for that is not set up in rural communities. Basically, what we're imagining is that the vaccines are going to be set up, let's say, in a warehouse or something, and then people are going to stand in a long line and we'll give the vaccine one after the next in that warehouse. In urban areas or states that are more densely populated, it's much easier to do that because a lot of people will live near a central processing place and it'll be easier to distribute. Whereas in a rural area where people live much further away, it's not very easy to set something like that up. So the Pfizer vaccine might not be a good candidate for rural areas. It might be more challenging. The Moderna vaccine can exist at a much higher temperature. So it just requires a regular freezer. It does not require these deep freezers or the extra dry ice or stuff that we're talking about. So it might be the case that Moderna's vaccine is what's more likely used in the rural areas. All right, follow-up question?
But going back to the question then, if you've got that situation where states have populations that are being vaccinated that are very low risk, you're still leaving states that are willing to be vaccinated with large populations that are at risk that aren't getting the vaccine. So your demographics are going to influence the number of people that actually get the vaccine and therefore die, or don't get the vaccine and then die.
That's true. Yep. All right. And what, yeah, it is what it is. I believe that right now the states are going to be the ones that decide. But I don't know exactly how it's going to roll out. Logistically, it would be optimal if we gave it to the highest risk first. But if the states decide and there's vaccine hesitancy, I don't know how that will play out. All right, Rebecca.
Maybe as time progresses, there will be sort of a redistribution and a reshuffling somehow of the vaccine, depending on supply and demand. Okay, but good questions. Thank you for those questions. All right, so we are almost at the end of our time together. How about we wrap up with two more questions? Let's talk about some risk calculators for the impact of the different scenarios of catching SARS-CoV-2. And if there's time, maybe you can briefly touch upon the current projections for the stay-at-home orders around the country. You know, it was interesting how when you normalize the data and you showed us California compared to the rest of the country, it was interesting how California had the stay-at-home order and so many other pockets of the country did not, yet they were faring far worse. So if there's time to answer those two questions, I'll let you steer the ship.
Absolutely. So I can go through this somewhat quick. So my favorite risk calculator is the one I've seen. I think it was from MIT. It's at this website, indoor-covid-safety.herokuf.com. And basically what they do is you plug in the size of the room, you plug in the number of people that are there, how many people are going to be wearing masks, average level of humidity, and then also the risk level of different people in the room. And it suggests how much on average it's safe to be in the room if one person is infected, is asymptomatic. Because if someone's infected and they're symptomatic, clearly you do not want them in that room with you. There should be no reason. Anyone symptomatic needs to isolate for at least 10 to 14 days. I know the CDC says it's a little bit less, but that's the CDC's recommendations is based on no symptoms. That's how much quarantine you need to quarantine if you think you were exposed. If you have symptoms, then it needs to be longer than that. It should probably be at least 2 weeks or so, but they should be talking with their physicians and deciding for themselves what is the right way. But you should not be having someone in your room who is symptomatic. Anyway, so this is assuming that one person is asymptomatic. And in some states, where we're seeing a boom of infections around the country, in some states, it might be more likely that there's more than one person who is asymptomatic in the room, in which case this doesn't count. Also, these are averages. And so in your room, it might be less. And so I wouldn't use this as like a threshold and just say, oh, phew, we're safe. Instead, it's an average. So, but it's interesting still, nonetheless, to see what the impact is of different protective events, protective interventions. So here's an example. Let's say we finished Thanksgiving. Let's say the holidays are coming up with Christmas or the other holidays for people who celebrate them, and you have a group of 10 people in a 20 by 20 dining room. You would take your mask off when you're not eating. Or rather, when you're eating, you would take your mask off. And the question is, if the air is of average humidity, one person's asymptomatic, how long can people stay in the room before they risk other people getting infected? And the answer is, based on the best available data that we have, 18 minutes. Only 18 minutes if one person is asymptomatic and you're eating together and there's 10 people in the room with you. All right, if you simply followed the 6-foot distance guideline that the CDC says, so even if you physically distanced, it would make no difference on that 18-minute time period. if you're indoors. Again, this is indoors in a 20-foot by 20-foot dining room. What if they were wearing masks? And so if you're assuming, okay, that you didn't eat, but you were instead hanging out in that 20-foot by 20-foot dining room for a period of time with 10 people, then let's assume no one ate. Then all that does is give you 2 more minutes of safety. So instead of 18 minutes, now you have 20 minutes you can stay in before another person is likely to become infected. And so what if you open the windows? The windows actually has a bigger impact, but that only buys you 6 more minutes. So between the 18 minutes plus the 2 minutes for the mask plus the 6, now you're at 26 minutes. So less than half an hour wearing masks with the windows open, less than a half an hour before someone else is likely to be infected. It changes based on the type of masks. This was assuming that people were wearing a diversity of masks and some were not fitting well. If you could be certain that everyone was wearing more surgical masks, the N95s, the surgical masks, and were wearing them properly, and by properly, I mean people who wear glasses, if you breathe in your mask and you can see fog on your glasses, then that's not proper. It means that it's not a very, very tight fit. There could be no air escaping from any of the sides at all. If there's air escaping, it's as if you're not wearing a mask at all in some ways. And because when there are surveys that have been done, they found that approximately half of the people don't wear them very tight. And so then it reduces the average back to half an hour. But if it were the case that everyone was wearing the best masks you could possibly get, and every single person was wearing them really tightly so that you could be sure that no one had fog on their glasses or whatever, then it could possibly go up to 2 hours. But again, I would not trust that most people are wearing their mask properly. In fact, I would say it's more likely the half an hour, that it's under half an hour where in terms of the likelihood of another person getting infected. Here's the risk calculator here. Whoops. Did I put it here? Nope, I didn't put it here, but there's the address that I gave you. Was this it? No. Nope. All right, so I can do it next week if you want, but this is the website, Indoor COVID Safety Hero KU app.com. Really cool. All right, next, let's talk about the other question that you had, which was
The other question is, and we'll wrap up for the evening with the question about the stay-at-home orders and looking at California and the decision to invoke the stay-at-home order when normalized at, I think you normalized it at 100,000. I'm not sure. I don't remember what that graph showed. What's your sense of what will happen in different areas around the country?
all right. So I think so. You're asking about the projections. What are when will states likely shut down? So interestingly, based on the rate that California was going, this IHME model that we've talked about in previous weeks, that they just released the latest one just a couple days ago, so Friday, they were expecting that there would be none. So November 19th, the previous one, they were expecting California would not shut down at all. And now in this model, they were not expecting that California would shut down for weeks until early January. But California is already shutting down because they are trying to get ahead of it. They don't want the number of deaths to get anywhere near as bad as they were in North Dakota or South Dakota. But when you look at the number of states that are likely to shut down in December, you can see there are a lot of states that are likely to shut down in December. Now, shutting it down is based on two things. The first thing is how bad things are in the state. And one of the best metrics for how bad things are is how many people are dying. How many people are dying per day and how big the hospitals, how much hospitalization there is in terms of the impact on the hospitals. That's one thing, looking at the impact. And then the second thing is the government of the state, how willing they are to shut down with that. So for instance, North Dakota and South Dakota, just two out of many, should have shut down weeks ago, but they haven't. And as a result, the hospitals are on the edge, and the number of people that are dying are way higher than they should have. They should have shut down weeks ago, but they chose not to. So simply having a lot of deaths or a lot of hospitalizations doesn't mean that a state will shut down. So that means that these projections aren't actually going to turn out to be reality, because a lot of states that should shut down won't end up shutting down. What that means is we'll have a lot more deaths than would normally be expected if we were another country or whatnot. So these are the states that we're looking at. A couple things I wanted to just compare just real quickly. So December. So this is the number of states that should be shutting down in December based on the number of cases, the number of hospitalizations, and the number of deaths. These are the ones in the coming weeks that should be shutting down. This is as of December 5th. The New York Times is tracking those with stay-at-home orders. Currently, only California, Ohio, Puerto Rico have orders or curfews in place. There are some advisories, but for the most part, none of these other states have put down these mandatory heavy stay-at-home orders like we saw back in March, April, May. Next, when you look at businesses, so there are some more restrictions on businesses in some of these states, but even though they don't have the full stay-at-home orders that they should probably be getting. When you look at the mask use, there's a lot of states to this day that still have no restrictions on masks, and some have only moderate restrictions. And so this is why the United States can't have nice things, because we don't care about people enough that you can't even have masks. The CDC has come out and said everyone in the country should be wearing masks when they leave the house. The Biden administration has said that this will be something that they'll see if they can promote when they come in. But right now, there are still plenty of states that are not having universal mandatory mask requirements. Here's another slide I like to compare. So this is even the states that do have mandatory mask requirements for people when they leave the house. You see that there's variation in terms of how many people actually report wearing masks. So these are people who actually report wearing masks on the left when they leave their house. So for instance, over here you have Louisiana, and what is this? Around 55 to 60% of them report wearing masks when they leave the house, but 100% of them should be wearing masks because they have mandates in place. So you see that there's a big discrepancy, and it's one of the reasons why the spread is going to continue to be really bad in different places. And there's a lot of places. So regardless of the mandates in place, there are a lot of states that are not wearing masks anywhere near where they should be. Oh, let me show you. So a key thing that people are going to be interested in: how bad is it likely to get? So here are the projections I mentioned earlier. Let me go back for 1 second. So this is, whoops, that's not what I want. I want, this is what I want. Oh, wait, where did it go? Here, this is what I want. So we're currently at over 2,100 deaths per day on average, and getting bigger. The question is, how high will that get? The numbers per day, deaths per day on average. And in fact, so we know that there's not data reported on weekends, and that's why the average is more interesting to look at. So over 2,100 currently. So right now, this projection is saying that by December, early December, we will have exceeded 2,100. I'm 2,000. This is where we are right now. We've exceeded 2,100. No matter what we do, we're likely to hit close to 2,750. And then we're going to see a difference depending on how things play out. If states don't shut down when they should be shutting down, then we will hit 3,000, and we'll potentially go much higher than 3,000 deaths per day. If instead states shut down, we get things more under control. I mean, so here's December, here's January, here's this is December. Yeah, so here's December, January. When Biden administration comes in, wherever we are, we could see more of a downwards numbers. This is based on the seasonality. That's why we see this curve here, because it's based on a normal, typical respiratory virus season, which is what we see for flu, what we saw in the southern hemisphere, and what we're fully expecting to see here in the northern hemisphere. The purple line is if 100% of people were to start wearing masks today, then this is what it would look like. You'd see a rapid decline, but that's not going to happen because we already saw how many people are willing to wear masks and how many people actually are. So most likely, based on this model, they're expecting that we will hit 3,000 deaths per day somewhere in January, but I'm expecting that we'll hit 3,000 deaths per day by the end of December, simply because we aren't seeing the state shut down that should be shutting down. And so I think that we're somewhere between the worst case scenario and the reference green. In terms of the impact on the vaccines, you see that even with the rollouts, and based on the number of people and the number of high risk people that are going to be getting sick and dying, we won't really start to see an impact until March, April, May in terms of some of the differences. So it's not really until March, April that you're really going to start to see any impact on the vaccines. So that means that the next few months, December, January, February, are really going to be some of the hardest months that we've seen in this country. I hope that the states shut down and that you can see the deaths here, what we're expecting versus what we had back in that early surge of April, March. I really hope that more of the country shuts down, because we're not in good shape.
All right. Well, following along with our theme of green, we're going to hope that we follow that green line or one of those green lines.
Rebecca, one more thing, because this is similar. I just want to end on this. So this was something that I saw from Snopes. And so there was some public health messaging that went out that said 1 in 800 North Dakotans died from COVID-19 by December. And Snopes looked at it and said, yes, it's true. And so for me, scratching my head as an epidemiologist, I'm like, yes, obviously it's true because that's what the numbers have been saying. But why was it a thing that had to go in front of Snopes? And I realized something, and that the way the numbers are presented makes a huge difference. So for instance, we'll end on this. So in the cases, nope, that's not what I want. I want this. So here, what we're looking at are the total deaths. And so this is total deaths per state, and then this is the total deaths per 100,000. And when you look at this, it's really hard to interpret total deaths per 100,000. It's kind of like a statistic. It's hard to interpret. It's kind of almost meaningless for most people. So take New York City, for instance. This is highest on the list. New York City had 290 deaths per 100,000. But then I thought, okay, well, let's reframe this the way that North Dakota did. If we were to reframe it the way that North Dakota did, how many people have died in New York City? And in New York City, framed that way, 1 in 346 people who live in New York City have died from COVID-19 so far this year. And when you frame it like this, I think it really drives it home in a different way. So I put this up here so people can see, regardless of what state they're in the United States, you can see in New Jersey, where I live, 1 in 518 people who live in New Jersey have died from COVID-19. In the United States as a whole, 1 in 1,190 have died from COVID-19. And these numbers are just as of December 4th. As weeks go on and we have more deaths, these numbers are going to shift, and they're going to be smaller and smaller in terms of the number, one per whatever number that we see in terms of the number of people that are dying from COVID-19 across the United States. So again, New York City was hit early on. So most of these people died back in March, April, May. And that was 1 in 346. They're still not, they were doing well for much of the year, but now the numbers are starting to rise. The hospitalizations and the deaths are starting to rise, even in New York City. When you look at some other places, North Dakota, which was 1 in 800 just a week or so before I pulled this data, you see that North Dakota is now 1 in 769. So the numbers are still shifting because people are continuing to die. So I think when you frame it this way, it really brings it home to people. And so please, everyone, take it to heart. Please stay safe. Please, if not for yourself, for everyone around you, wear your masks. Stay outdoors. If you need to go outside with other people, don't go indoors if you can. And if you need to go indoors, limit your time there to as small amount of time as possible, and reduce the number of people that you're exposed to, but stay at home if at all possible. All right, Rebecca, thanks. Back to you.
Thank you, Glenn. Tremendous, amazing advice as always. We really, really appreciate all that you're doing. Really, we really can't thank you enough. And to everybody on this Zoom call, everybody in your boxes with us live, and those who are watching this discussion via YouTube, please keep sending those questions in. It is really, really helpful in framing our conversations. So we will see you next time, next Sunday, same time, same place. And everybody be safe, be well. And again, keeping everybody in our thoughts and prayers, and be well. Take care. Bye-bye.
Thanks, Rebecca. Thanks, everyone. Have a great week. Bye-bye.